We are ready.
I'm starting now. Good evening, everybody. On behalf of All India Ophthalmological Society and the ARC, it gives me great pleasure to welcome all of you to today's webinar, which is titled Compression to Decompression, a Surgical and Diagnostic Journey Along the Optic Nerve. Very much honored to have this session, and also I believe that it brings together a distinguished panel of experts, and all these experts have dedicated their career to unravel the complexities of the optic nerve disorders. I'm sure the wealth of experience will guide us all to manage or to have make a critical decision involved in managing and diagnosing the optic nerve pathologies. This webinar is designed not only just with lectures, but is a platform for learning for all of us, for dialogues and the clinical growth. So I'm sure it'll ignite sparks and have meaningful discussion. I would like to thank each one, all the faculty for being with us, Dr. Grover, sir, for being the chairperson of today's session, Dr. Anita being the moderator, and Dr. Usha Kim will be joining us a bit later. And to all the faculty being with us, with this, I request Grover, sir, to kindly open the session and to give your chairman remark, and Dr. Anita to please moderate the session.
Thank you, Kasturi. It's really wonderful to have this session dedicated to optic nerve pathologies and their surgical or diagnostic features. So I think this is unusual. I've not attended one where it is dedicated only to optic nerve, and it has covered some very useful subjects, including the decompressions for idiopathic intracranial hypertension for purposes of tumors, for purposes of traumatic neuropathy. So we're going to enjoy this session. There'll be a lot of challenging, lot of nice things that we'll get to do. Thank you, Kasturi, for organizing this. Thank you, ARC, and thank you, the entire team, for this wonderful session. Looking forward to it.
Now I request Dr. Anita to please start the session.
Yeah. Thank you, Dr. Kasturi. I agree with Dr. Grover. This is really a wonderful initiative, and I'm really happy that we are actually examining something which, being at the back of the orbit, somehow we don't get beyond aesthetics and we don't reach there. So I'm just going to introduce our star-studded faculty. Of course, there is Dr. Kasturi, our program coordinator. Amazing drive and a wonderful orbital and aesthetic and oculoplastic surgeon. She's just an all-in-one. And of course, there's our chairman, Dr. Grover, who is, I think, I don't want to call him father, but he really is the father of oculoplasty. And we are always so honored and so privileged to have him guide us. Our co-chairman is Dr. Usha Kim. She will be joining us, also a wonderful oculoplastic surgeon, has been the president of the OPAI, and really, I'm sure we will learn a lot from her. The talks are also wonderful talks, and our first talk is, let's start at the very beginning, Anatomy and Physiology of the Optic Nerve by Dr. Ruju Unatkar. And then we will go on to the next node of our journey, which will be Identifying Compression by Dr. Ashmin Gandhi. And then more about the tumors, where our our king of ocular oncology, Dr. Santosh, will be telling us about the optic nerve tumors. And then we will talk about the orbital decompression. Dr. Tarjini Dave will do that first. The next will be optic nerve decompression for benign intracranial hypertension, which Dr. Mukesh will take us through that. Optic nerve canal decompression for thyroid optic neuropathy, another very, very important subject which Dr. Kasturi will tell us. And then we will have two interactive case presentations by our young upcoming oculoplasty surgeons, orbital surgeons, Dr. Yashdeep and Dr. Farnaz. So it's really going to be a wonderful program, and we hope to have a lot of interaction, a lot of discussion. So I'm going to set the ball rolling. Opening batsman is Dr. Ruju. Over to you, Dr. Ruju.
My slides are visible.
Yeah.
Hello and very good evening to all. I am extremely grateful to AIOS and ARC for giving me this wonderful opportunity to speak on anatomy of optic nerve. So let's start this journey where light becomes sight. Next 9 minutes, I'll be covering this topic under the subheadings. Because of the time constraint, my focus will be primarily on oculoplasty related optic nerve anatomy with just a brief touch on aspects related to glaucoma and neuroophthalmology. A brief glimpse into historical milestones that shaped our understanding of the optic nerve starts with Aristotle, who described optic nerve as joining at the optic chiasma, so called because it resembles with the Greek letter chi. Getriolet, 1700 years later, using soft orange wood sticks for blunt dissection, was able to follow the retinofugal projection to the pretectum as well as confirm the main pathway to lateral geniculate nucleus. Optic nerve fibers develop from the nerve fiber layer of the retina, which grow into the optic stalk by passing through choroidal fissure. Any defect in this process can lead to optic nerve anomalies such as optic disc coloboma, morning glory disc pit, or disc hypoplasia. Myelination of the nerve fiber begins from the chiasma at about 7th month and reaches the lamina cribrosa just before birth and stops there. When myelination continues beyond the lamina cribrosa, medullated nerve fiber layer is formed. This second cranial nerve spans approximately 50 mm in length and houses over 1.2 million axons from disc to chiasma. But what sets this optic nerve truly apart from other peripheral nerve is it is an outgrowth of the brain, reflecting its central nervous system origin, and unlike other peripheral nerves, it is not covered by neurolemma, which renders it incapable of regeneration. Its fibers are exceptionally thin, ranging from 2 to 10 microns. Uniquely, the optic nerve is enveloped by all three meningeal layers, dura, arachnoid, and pia mater, forming an extension of the subarachnoid space, thus allowing pathological processes within the subarachnoid space to readily spread along the intraorbital segment of the optic nerve. This diagram illustrates the organized arrangement of nerve fibers in the retina as they converge onto the optic disc. Nasal retinal fibers project directly to the disc as superior and inferior radiating fibers. Macular fibers travel straight to the temporal side of the disc, forming papillomacular bundle, and temporal fibers arch above and below the macula as superior and inferior arcuate fibers separated by a horizontal raphing. Due to the nasal preponderance of nerve fiber thickness, early signs of papilloedema typically manifest in the nasal retina. At the optic nerve head, peripheral retinal fibers lie deeper in the retina and occupy the outermost part of the optic disc. Hence, arcuate fibers are most sensitive to glaucomatous damage. In contrast, fibers originating closer to disc lie more superficially and enters the central region of the optic nerve head, making macular fibers most resistant to glaucomatous damage. Anatomically, optic nerve is further divided into four segments: intraocular, intraorbital, intracanalicular, and intracranial. Let's start with understanding the intraocular part, which is 1 millimeter in length. It passes through the sclera, lamina cribrosa, and choroid to appear as the optic disc. It is subdivided into four sequential regions: surface nerve fiber layer, prelaminar, lamina cribrosa, and retrolaminar. Fiber layer is composed of axonal bundles with 94% of nerve fibers and 5% of astrocytes. Astrocytes and neurons increase in number as they approach the prelaminar region. Border tissue of Jacobi separates the nerve from choroid, and due to this reason, disc swells so easily in papilloedema while adjacent retina does not swell. Lamina cribrosa is fibrillar, sieve-like structure with 200 to 300 fenestration. It has got a rich blood supply from circle of Ziem. In retrolamina region, astrocytes decrease and oligodendrocytes increase to cause myelin. Addition of this myelin sheath doubles to the diameter of optic nerve from 1.5 to 3 millimeter. Intraorbital part of optic nerve, which is 25 millimeter in length, has sinus path which allows the eye movements. Anteriorly, it is separated from the extraocular muscles by orbital fat, and posteriorly, near the optic foramina, it is surrounded by annulus of Zinn, some fibers of superior and medial rectus adherent to its sheath, which causes painful ocular movements in retrobulbar neuritis. Central retinal artery with vein enters the nerve on its inferomedial aspect about 10 millimeter from the eyeball. This fact should always be kept in mind while operating on optic nerve. Any undue manipulation can result in CRO. Long and short ciliary nerves and arteries surround the optic nerve before this enter the eyeball. Laterally, between the optic nerve and lateral rectus lie the ciliary ganglion, branches of the oculomotor nerve, nasociliary nerve, sympathetic fibers, and abducens nerve. In optic canal, ophthalmic artery lies close to its relation, crossing the optic nerve inferiorly from medial to lateral within the dural sheath, exiting at the orbital end. Ophthalmic artery then along the superior ophthalmic vein and nasociliary nerve cross superior to the optic nerve from lateral to medial. Intracanalicular part of optic nerve measures 9 to 10 millimeter. The optic canal is located in the lacer wing of sphenoid bone. Sphenoid and posterior ethmoidal sinuses lie medial to the optic canal, separated by thin bony lamina, making the optic nerves susceptible to retrobulbar neuritis in cases with sinus infections. Intracranial part of optic nerve lies above the cavernous sinus and joins the opposite optic nerve to form optic chiasma. Initially covered only by pyometer, it acquires the arachnoid and dural sheath as it enters the optic canal. Internal carotid artery lies below and lateral to the nerve. Ophthalmic artery arises from it, running beneath the optic nerve. Having understood the anatomy in detail, let's now shift our focus to how these structures guide our decisions in operating room. So, for orbital tumor management, radiotherapy or careful debulking is often preferred for optic nerve tumors to minimize the risk of vision loss from direct nerve manipulation. During the removal of adjacent orbital tumors, it is critical to avoid traction or pressure on the optic nerve, as even a minimal disturbance can lead to irreversible visual impairment. Optic nerve decompression involves removing the bony roof and the medial wall of the optic canal using a diamond burr to avoid any thermal damage. Careful dissection avoids the injury to the ophthalmic artery and nerve traction or dural tears. Therefore, the use of image-guided navigation is strongly recommended to enhance the surgical precision. During orbital decompression, it is essential to avoid excessive removal of posteromedial wall and orbital floor. The endonasal endoscopic approach provides excellent access with minimal disruption. Post-operatively, careful monitoring of visual acuity, color vision, and pupillary reflexes is crucial for early detection of optic nerve compromise. To accurately localize the optic nerve during optic nerve sheath fenestrations, surgeon can follow the course of the ciliary arteries which run in close proximity to the nerve in posterior orbit. It is critical to avoid dissecting more than 10 millimeter posterior to the globe to minimize the risk of damaging the central retinal artery. The lack of neurilemma around the optic nerve prevents spontaneous closure of the fenestration window, allowing the sustained CSF drainage and long-term decompression. Lastly, I would like to say optic nerve may just have a span of few millimeters, but it carries the weight of entire vision. As oculoplastic surgeons, our responsibility lies not just in navigating its anatomy, but in respecting its elegance. Thank you so much for your kind attention.
Thank you, Dr. Ruju. I think that was a really good demonstration of the anatomy and the applied anatomy. I think we'll keep the discussions for after all the talks, Kasturi. Is that
Yes,
okay?
yeah, that will be better. Yeah.
Yeah, so we'll
Very
discuss.
nice.
It's a really very nice presentation, Dr. Ruju, and we will discuss it later. I now invite Dr. Rashmin Gandhi. His topic, he's a very well-recognized neuro-ophthalmologist, and there are not too many of them. So we are really looking forward to hearing what he has to say. This is Diagnostic Journey, Identifying Compression. So Dr. Rashmin, over to you.
Thank you so much, Dr. Rita, for that very kind introduction. Uh, First of all, thank you, AIOS ARC, Dr. Kasturi, Dr. Prashant, for this very kind invite. It's really a wonderfully crafted session, and thank you for making me part of it. So as was mentioned, my role is to say what are the pointers in our day-to-day life towards a compression of optic nerve and the other parts of visual pathway. So let me give you, and these are all real life cases. This was a patient who actually traveled from Iraq for second opinion. He said that I was hit on the head repeatedly by the soldiers, and after that, my vision gradually went down. His visual acuity in the right eye, affected eye, was 2/60. The other eye was 6/9. He didn't have any problem in the other eye. He was told locally that this is the clear case of traumatic optic neuropathy, and really nothing can be done. So he came for the second opinion. This is how his optic nerves look like. The affected eye, the right optic nerve, has a very impressive optic atrophy. If you look at the left eye carefully, however, and this was very nicely illustrated by Dr. Ruju in her talk, uh, left eye has what is described as bow tie optic atrophy. If you look at carefully, the nasal and temporal raphe are pale, while the superior and inferior poles are still pink. And this, the basis of this bow tie or a band-shaped optic atrophy is in what Ruju described, the anatomical arrangement of the fibers, wherein the arcuate fibers get attached to the superior and inferior pole of the disc, which are spared in this case, versus the nasal fibers, nasal macula, are affected. And that's the reason why there is a bow tie optic atrophy. So now if you go back, even in the history, patient was very clear that after that unfortunate incident of violence, his visual acuity actually gradually went down. So these were very clear pointers: gradual loss of vision, which is not really a characteristic of traumatic optic neuropathy, unless there is a bone fragment which is impinging on the optic nerve, causing a compression of optic nerve. Otherwise, traumatic optic neuropathy would always have a gradually progressive loss of vision. And even a sign in the eye where patient did not have symptoms. Patient underwent a visual field examination, and you can see clearly the right eye, which is the affected eye, has gross reduction of sensitivity. However, in the unaffected eye, patient also has, or the eye where patient did not have symptoms, you can see there is a supratemporal visual field defect. Now, this visual field defect is called junctional scotoma, where you have an optic nerve defect, which can be a defect like this, or can be a central scotoma, or it can be even an arcuate defect, which is basically any defect which corresponds to an optic nerve damage, and a supratemporal defect in the other eye. Combining all three, patient underwent neuroimaging, which was not done locally, and we found that there was actually a pituitary tumor which was sitting right on the optic chiasm, and the history of trauma was incidental. So this was a first lesson where you say that this was a compression of a visual pathway, and a clear pointers which were missed out in the initial workup was gradually progressive loss of vision, the signs in the other eye, a temporal visual field defect in the left eye, and a visual field defect which was respecting a vertical midline. These are all 4 pointers towards compression of the optic nerve. So that was case number 1. Sometimes patient can present with this clear-cut bitemporal defect where you know that this patient has a chiasmal compression. Patient can also have these kind of optic nerve defects occasionally, which can have these kind of, if you see these kind of visual field defect where you have a respect to the vertical midline, you know that you're dealing with a visual pathway lesion. And in younger patient, it can be compression. Since the theme of our topic for discussion is compression, and this is again a visual field defect. This is left homonymous hemianopia, again a visual field defect which respects vertical midline. Visual field defect which is mainly central or arcuate or alternate like this. These are all defects which can be because of the compression of the visual path. And this was a very nice paper which was done by our colleagues at Shankar Netralaya, which was published around 15 years ago in IGO, where they looked at the files of 6 patients where the diagnosis of compression initially was missed. Patient was treated with some other diagnosis, and later on it was found that patient was actually having a compression of either an optic nerve or a visual pathway. And it's quite telling. The results here, you can say that there are patients where pupil was not checked or visual field was not really done or visual field were not really corroborated with the clinical findings. So in other words, we looked at case number 1, where we learned that a gradually progressive loss of vision, defect in the other eye, vertical respect in a visual field defect, or a central defect are all pointed towards compression. Now let's move to a second case. Compression of the optic nerve need not be a solid mass. It can be because of the fluid, and was also mentioned by Ruju. So here I'll highlight how do you diagnose a liquid or a pressure compression on the optic nerve and what is our role. So this is a 30-year-old female who had a increased body mass index, a little obese female on oral contraceptive pills, complaining of headache and visual symptoms, and had a bilateral disc edema. And you can see here OCT showing increased average RNFL thickness. You can see in the visual field, however, patient had enlarged blind spot. These are all pointers towards increased intraocular pressure, pressure of the optic nerve or compression of the optic nerve with the fluid. So let's look at how do you diagnose a patient with increased intraocular pressure. I'm not going to talk about treatment because Dr. Mukesh Sharma is going to talk about the optic nerve sheath fenestration. But the most important symptom in patients with raised intraocular pressure is headache, which is present in 90% of the patients, which is generally bilateral. It is more common in the mornings. However, there are other symptoms which are quite pointing towards raised ICP. The most important one after headache is transient visual obscuration, which is present in up to 70% of the patients. Generally, it is described as browning out of the vision. It is positional. It is generally seen when the patient gets up from a supine position, and it lasts for a few seconds. Patient can also have tinnitus, backache, dizziness, photophobia, and all these other list of symptoms. So that is number 1, pointer towards compression. These are all symptoms, and bilateral disc edema. If you have ruled out other features like hypertensive retinopathy, you know that you're dealing with raised intraocular pressure. When patient has raised intraocular pressure, papilledema, and when you have ruled out the cause, or if you don't know what the cause is, then you label it as idiopathic intraocular hypertension. Now, what is our role apart from diagnosis? So this signifies a major role in these patients. 24-year-old female actually did not have any visual problem. Her vision was 6/6. She went to a neurologist first with this kind of picture where there was a bilateral disc edema with headache. Patient was diagnosed as in raised intraocular pressure. Since patient did not really have, and it was IIH because there was no etiology found. Since there was no visual symptom, patient was actually started on a very mild dose of acetazolamide. However, if you see, a patient was complaining of mild uneasiness when she looked to the left. And if you look at that oculomotility, you'll find that patient is looking to the left. Actually, there is a little limitation of abduction in the left eye, which is a sign of raised intraocular pressure, which is probably higher than what we thought or what they suggest. And if you look at the visual fields, however, you find that patient actually has a very advanced visual field defect. Patient is not complaining of visual problem because the central visual field is fine. But this is a chronic advanced visual field defect, which tells you that the minimal dose is not really something which is sufficient for this patient, which is further signified by OCT, where you say that there is a increased RNFL. However, if you look at the GCC, there is a marked reduction of GCC. So in other words, Here is a patient which is on a very mild dose of acetazolamide because the visual symptoms are not really very severe. But you can clearly see that she's actually on the edge. If she's not treated aggressively, she can actually tip over to a really advanced vision loss, which can be irreversible. So this kind of patient would require an aggressive treatment. Aggressive treatment can be an aggressive medical treatment or a surgical treatment, which Dr. Mukesh will talk about. So OCT, so I also want to say that in compression, we're talking about compression of optic nerve because of the fluidic pressure like raised ICP, papilledema. OCT has now a huge role to play. You can actually it has a diagnostic value. You can differentiate between a pseudo disc edema and a disc edema using OCT and fairly well now, and a prognostication. It can give you, if there is an advanced loss of GCC, you know that patient actually is losing axons and your treatment may or may not have an impact. Patient having a tumor of a visual pathway already has an average RNFL which is less than 60. You know that tumor removal may or may not relieve her visual field defect. Conversely, if the average RNFL is more than 90, you know that the prognosis of recovery of vision and visual field would be good in those patients. So OCT has assumed importance now in prognostication in these patients with compression. I'll end with this last case where a compression, and I'm not going to talk about orbital tumors because Santosh is going to talk about it, but patient can have a compression because he or she may have a problem like this. And look at this patient who has a vision loss. And you see here, patient looks to the left, there is a loss of adduction. Look carefully, if patient looks to the left, the abduction is there, but if you look at it carefully, the abduction was not fast enough, and there is a limitation of elevation, limitation of depression. So let's see if there is a torsional movement. You find that when the patient looks from up to down in the abducted position, you will not find the intorsion of the eye, implying that patient also has, apart from the third nerve, fourth nerve also is gone. And now if you look at the abduction in the right eye carefully, you'll find that the abduction also was slow, signifying that patient also has a sixth nerve problem. So here is a patient who has a vision loss, no vision loss, but has a ocular motility issue where there's a third nerve issue, fourth nerve gone, and also a sixth nerve, which is gone. So you know that now you're localizing this compression somewhere in the cavernous sinus. If the same patient had a vision loss, then you localize it to orbit. But if all these nerves are gone, but the vision is fine, localize the cavernous sinus. And this patient actually had, as you find here, a cavernous sinus SOL, which was actually turned out to be a large aneurysm of cavernous sinus. So this that tells me to the last slide. So what kind of investigation that we should request for in these patients? Patient who has a predominant vision loss, which is unilateral or bilateral, the first investigation of choice would be MRI brain and orbit with contrast. If patient has an ocular motility issue, MRA would be there. Even if we are not able to request, or if we are not requesting, we should make sure that the radiologist is aware as to where we are roughly localizing a lesion, so they will go for MRA if they don't find anything in MRI. Similarly, if patient has a raised intracranial pressure, we should make sure that MRV is in the mix of the diagnostic arbitrum, because we want to rule out the thrombosis of thrombosis of venous sinuses in the brain, which again, with contrast, which a radiologist should be aware. So to conclude, compression of the optic nerve or visual pathway, we do have a large role to play in diagnosis, and one or any of these steps, if they are missed, actually it can have a disastrous consequences. Thank you once again.
Thank you, Dr. Ashwin. Yes, that was a really wonderful and concise, but you covered everything. Thank you so much for highlighting all these points. I especially like the part that you highlighted, the importance of a complete investigation in any case where we're suspecting compression. Something as simple as pupil getting missed is just really unacceptable. So I think highlighting the importance of OCT for prognosis, and highlighting a complete examination in all cases of idiopathic intracranial hypertension. Really wonderful. Thank you so much, Rashmin. And I'm sure we'll discuss it some more when everyone's spoken. So yeah, thanks, Rashmin. We now move on to the next speaker.
Our next speaker to take OPM membership, and
yes,
we should have one neuro-ophtha session. So much to learn from neuro-ophthalmology.
There is so much. Really, it was really wonderful.
Welcome
Rashmin,
to
yes.
OPI Group.
Thank you.
Please do stay until the end because I'm sure everyone has questions and we would like to discuss all of this
Sure,
further.
I'll begin. Absolutely.
We now go on to our next speaker, Dr. Santosh. Dr. Santosh needs no introduction. He is really tells us everything about tumors and more. Santosh, are you here? Yes,
Yeah.
you are. So he's going to talk to us about optic nerve tumors, and we look forward to hearing.
Thank
from
you, Anita. Thanks for the kind words. I'm going to speak about two optic nerve tumors. There are many, of course. I'm talking about optic nerve glioma and optic nerve sheath meningioma, which are the most common optic nerve tumors. Starting with optic nerve glioma, it is a low-grade astrocytic tumor involving the entire optic tract. In fact, it can involve just the optic nerve, the orbital part of the optic nerve. It can involve the chiasm or the optic tract. It typically affects children, and that is how it presents, but it can involve adults as well, young adults, and even elderly individuals. Benign in histology, but it is potentially blinding. And if you look at the epidemiology, it accounts for about 1 to 5% of all orbital tumors, depending on the series that you look at. In referral hospitals, it may be a little more, whereas in non-referral hospitals, it may be a little less. 75% occur in children. So if you have a child with axial or abaxial, unilateral or bilateral proptosis with signs of neurofibromatosis, your first diagnosis would be an optic nerve glioma. 20 to 50% of them would have signs of neurofibromatosis. Younger babies may not have signs of neurofibromatosis yet, but they may develop such signs later. It's rare in adults, and adult cases are often aggressive. It's usually a pilocytic astrocytoma, WHO grade 1. Typically, ones which are associated with neurofibromatosis are indolent and tend to be bilateral, and they could be bilateral asymmetrical with a very subtle optic nerve glioma on the contralateral side. However, the sporadic ones are typically unilateral. They can rarely be bilateral and may show very aggressive clinical behavior. I'll elaborate on that a little later. Clinical features, if it's an older child, you may notice visual inattention, or if it is a bilateral lesion in a young infant, again, you'll notice visual inattention. Older children will also complain of progressive vision loss. When you look at the optic disc, you may find disc pallor or edema or a combination of both. There would be either axial or abaxial proptosis depending on the displacement of the glioma. Glioma does not always remain in the core of the orbit. It can get displaced by way of kinking, either superiorly or inferiorly, medially or laterally, displacing the eyeball in the opposite direction. Although axial proptosis is the most common manifestation in about 75% of children. Squint is possible. Squint does occur. There would be afferent pupillary defect, and adult cases may actually look like meningioma. MRI is the imaging modality of choice. CTs can be used for screening, of course, but if you are talking about prognostication, if you're talking about triaging management modalities, then MRI must be done, and in which you find fusiform enlargement of the optic nerve. This is very, very classic, with or without kinking, and it is typically iso or hypointense on T1 and variable contrast enhancement. It is hyperintense on T2. Contrast enhancement would be variable. And if you are keen on doing a biopsy for some reason, if it is an atypical clinical presentation, then you ask for the recent advance, that is diffuse tensor imaging or DTI, where the radiologist would be able to localize the normal nerve fibers. So you can actually go to the opposite side of, suppose the radiologist localizes the normal nerve fibers here. If it's an eccentric optic nerve glioma like that, localizes normal fibers on this side, then you would biopsy from the opposite side to minimize loss of vision or reduction in visual prognosis. MRI perfusion also helps you assess the optic nerve integrity. So if you're looking at biopsy, then ask for these two special measures on MRI scan. this is how kinking appears. You can see kinking here, very nice kinking. This could be anterior kinking in like this in a patient with neurofibromatosis, where in a non-NF patient, it would be a posterior kinking. That's very, very typical. And this is variable contrast enhancement on MRI scan. Natural history in children, it's often indolent, stable for several years. So just because you have seen an optic nerve glioma, there is no point rushing to treatment. Whereas in adults, it is aggressive and progressive. Adult optic nerve glioma can actually be malignant, that is called glioblastoma, and more frequent intervention is needed in adults. Actually, many orbital surgeons tend to biopsy if the manifestation is atypical, especially if a patient has nerve fiber layer hemorrhage, severe disc edema, rapidly progressive course, loss of vision, intracranial extension. Then adults, these are manifestations of glioblastoma and would need a biopsy. PET scan also helps you differentiate a glioma from a glioblastoma. Now, this is important to differentiate non-NF optic nerve glioma versus NF optic nerve glioma. In non-NF, patients actually presents with symptoms, whereas in NF, they are asymptomatic and they may be discovered on screening in a child with other features of neurofibromatosis. When you do imaging, you may find silently lying optic nerve gliomas. In non-NF, two-thirds of them progress, whereas in NF, only 10% progress. Non-NF also shows rapid growth. It tends to be unilateral. It is fusiform with a distal kink as opposed to proximal kink in non-NF optic nerve glioma. There is loss of perineural space, whereas in NF, there is arachnoid gliomatosis, which is an MRI feature. It tends to be intrinsic and axial that explains loss of vision, whereas in NF, it is paraxial. That means that if this is the optic nerve, it could be on one side of the optic nerve, and that is the reason why these children continue to maintain some amount of vision for a very long time. Chiasmal hypothalamic and extension and hydrocephalus are common in non-NF optic nerve glioma. Now, management of pediatric optic nerve glioma, observation is definitely justified if vision is good. If you can measure vision or do a VEP and find that is reasonably normal and the tumor is stable on serial MRI, you can definitely observe. But if a lesion is progressing, or if you find that the vision is subnormal, or if the patient already had disc edema or hint of pallor, or if you're documented progression, then chemotherapy is the first line of management. Chemotherapy is the treatment of choice in any child under 3 years of age, and definitely one of the main consideration in any child who's under 6 years of age. So it's an absolute indication for every child who's under 3 years of age, and it's recommended in children up to 6 years of age, whereas beyond 6 years, radiation may be the treatment of choice. Surgery is rarely ever needed and it is only done in disfiguring prognosis. Now, when we talk about chemotherapy, this is the drug of choice. Carboplatin and vincristine, relatively inexpensive, and it has a very high safety profile. In fact, we use carboplatin and vincristine along with etoposide for the management of retinoblastoma. We can also use vinblastine or temozolomide as alternatives. Target therapy is definitely coming in. Metinib, which is a MEK inhibitor, or mTOR inhibitor such as sirolimus are being used, and even bevacizumab is being used in adult cases with vision loss. That's because NF1 is caused by a pathogenic variant in the NF1 tumor suppressor gene, which is identifiable. You can actually do this genetic analysis, which is available in India. In 90% of cases, the mutation leads to loss of function of NF1 gene product that is neurofibrin. Now, NF1 associated optic nerve glioma can be treated with MEK inhibitors, mTOR inhibitors, and bevacizumab. As I already mentioned, selumetinib is the drug of choice as far as a MEK inhibitor is concerned, and for mTOR inhibitors, we have sirolimus. Bevacizumab can be also used in adult optic nerve glioma, as I mentioned. Surgery is rarely indicated and it is done in disfiguring proptosis. Risk of vision obviously is there. This is a child where there was no vision and it was going into the intracanalicular segment, so a lateral orbitotomy was done and the tumor was excised. This child has disfiguring proptosis with loss of vision, so we did enucleation along with excision of the tumor, and of course the child could be rehabilitated with the custom ocular prosthesis. Radiation is generally avoided in children under 6 years of age, and it is considered for adult optic nerve glioma. This was a child who has undergone radiation, and for some reason, this child had absent perception of light, severe disc edema at initial manifestation. There is very good aesthetic cosmetic recovery, and surprisingly vision returned to 6 by 9 after neuroprotective stereotactic fractionated external beam radiation. This is the pre-EBRT MRI picture. This is post-EBRT MRI picture. You can actually see nice regression even on MRI. This again a child with PL positive with neurofibromatosis. You can see signs of NF here, recovered to 6 by 9 post radiation, and you can see reduction in the size of the optic nerve glioma as well. Prognosis is good in children with NF1. They maintain stable vision. Visual outcomes are poor in sporadic and adult cases, and molecular markers currently guide the prognosis. The molecular profiling is now recommended in F1 gene and also IDH and H3K27M. These are prognostic markers. And it is also currently recommended that MEK inhibitors, if they're used earlier in NF1 related cases, can also treat other manifestations of NF and prolonged life. They can even treat a evolving eyelid manifestation, which is plexiform neurofibroma or facial neurofibromatosis as well. OCT and advanced MRI help guide therapy, and of course, multidisciplinary care is emphasized. In optic nerve sheath meningioma, it's a benign, slow-growing tumor from arachnoid cap cells of the optic nerve sheath. It causes morbidity because of loss of vision. Now, it accounts for about 2% of orbital tumors and 1 to 2% of meningiomas overall. So it's extremely rare in the realm of orbital pathologies and also as subgroup of meningiomas. Typical age group is 40 to 50 years with a strong female preponderance, and for some reason, females tend to have it little later than males. And even here, about 10% of them would have NF2, where it tends to be bilateral. Orbital segment is most commonly involved, can extend to canalicular or intracanalicular segments. And there are 3 patterns on MRI, which I'll show a little later. On histopathology, it is WHO grade 1 meningothelial psammomatous tumors with common, about 30% of them will have manifest calcification. For the sake of postgraduates, they're often asked about Hoyt-Spencer triad. It's a triad of painless progressive visual loss, which is a symptom, optic atrophy, which is a sign, and optociliary shunt vessels. And at the time of presentation, a majority of them present with good vision, which also prognosticates the ultimate vision. If a patient presents with poor vision, that's a prognostication sign for poor visual prognosis. The patients don't generally recover if they present with a poor vision, except in exceptional situations following maximal or optimal management. Very few of them have severe proptosis. This patient came for cataract surgery and was noted to have relative afferent pupillary defect. The proptosis is extremely subtle despite this lesion because it's a very slow growing lesion. When you look at the fundus, you may find disc pallor, mild to severe, and most importantly, you find optociliary shunt vessels. You can see the optociliary shunt vessels here, which is very evident when you magnify, look at the disc in magnification. There's a hint of pale disc edema and pallor as well. This is present in about 60% of patients. Common visual field defects are shown here. You can do baseline visual field so that you can monitor response to treatment. MRI with contrast enhancement with fat suppression is the way to image these patients. CT scan really does not help prognosticate. Where you may find that there could be a tram track sign. This is a typical feature on MRI, but you can also see tram track sign on CT scan. On CT scan, you also find calcification. There are 2 MRI features which are typical: tram track sign on axial, and on coronal scan, you find the donut sign. T1 hypointense in a majority of patients. T2 iso to hypointense. It is totally reverse of optic nerve glioma, and intense contrast enhancement are the features of optic nerve sheath meningioma. This is fusiform expansion. This is type 1A. Tubular expansion or concentric mass is type 1B. Globular expansion with exophytic growth is 1C. 2 is when it extends through the optic canal 2B is 2A, that is 2A. 2B is tumor of orbital apex with extension through the superior orbital fissure and to cavernous sinus. 3 is intracranial extension to the chiasm, etc. So there are differential diagnoses, but the manifestation is very typical, not to miss. Natural history, virtually no morbidity, but of course visual symptoms and signs manifest. Options: if a patient has good vision and a slow growing lesion, observation. Otherwise, fractionated stereotactic radiation. There is no role for chemotherapy here. There is no target therapy yet that can take care of optic nerve sheath meningioma. So observation is appropriate for small tumors with no visual morbidity. Then you monitor them with MRI every 6 months. When you give fractionated stereotactic radiation, about half of them will have stabilization of vision, 40% will have actually improvement of vision, and about 10% despite stereotactic radiation deteriorate. For that matter, when you use stereotactic radiation to avoid this loss of vision, you do what is called neuroprotective. You give a concurrent steroid treatment, oral steroids, sometimes even intravenous steroids with B1, B6, B12, so that the optic nerve is protected during the process of radiation. Optociliary shunt vessels also regress. This is an example of a patient with a recovery of vision 3/60 following stereotactic radiation. You can also see nice regression in the thickness of the optic nerve post EBRT. Tumor has regressed. There's one more example of an adult who has recovered to 6/6 following external beam radiation. And you can also see nice regression and the stable regression in this patient following EBRT. This was a patient where the patient actually had vision of 6/6 with disc edema. Vision remained stable, and you can see nice regression in the size of the tumor following external beam radiation. This patient gained good vision. She had 624 to begin with. She recovered to 6/6 following radiation. And you can see this kind of a tumor here at the posterior orbit, which is completely resolved following radiation. Proton beam therapy can be used for patients who have a very critical location of the tumor where stereotactic radiation may not work. Stereotactic radiosurgery is not recommended because it has a high risk of radiation-induced optic neuropathy. It is not used as a first-line therapy. Surgery is typically not performed unless for a biopsy. It again calls for multidisciplinary approach and follow-up guidelines. Every 6 months, you have to assess vision, if possible fields, and MRI up to 2 years. Then it would be annual. OCT, RNFL, and fields can also be performed as follow-up measures. Late manifestations obviously should be looked for, such as radiation retinopathy, cataract, and optic neuropathy. Of course, these are some of the recent advances. Early radiotherapy correlates with better visual outcomes. So if a patient even has very subtle progression or even one line loss of vision or contrast sensitivity or abnormal VEP, then it is justified to do radiation as soon as possible. It has to be neuroprotective radiation. Perioptic cysts on MRI may indicate compressive severity. So if a patient has perioptic nerve cysts which are seen on MRI, then again early radiotherapy is indicated. Biopsy should definitely be avoided, and radiation has been found to be safe and effective. In summary, both are benign, optic nerve glioma and optic nerve sheath meningioma, but both are definitely sight-threatening. Diagnosis is image-based, not biopsy. You have to differentiate NF1 associated with optic nerve glioma versus non-NF1 associated with optic nerve glioma, which are totally different prognosis. So treatment has to be accelerated in patients who don't have NF1. Chemotherapy and target therapy are the treatment of choice for optic nerve glioma, whereas fractionated stereotactic radiation is the first line of treatment in optic nerve sheath meningioma. Observation is safe for stable small lesions. Surgery is extremely rarely performed in optic nerve glioma, that too for patients who have cosmetic abnormality. Thank you so much.
Thank you, Santosh. That was really a wonderful presentation. Thank you for highlighting the importance between, differentiating between the neurofibroma related and non-neurofibroma related. And it's particularly interesting to hear how well radiation can, do in these cases. And we really need to know when to refer. So that and also the exciting, the genetic part, genetics is going to play in this, and molecular profiling. So we look forward to more of that, and maybe we'll discuss again at the end. But thanks a lot. That was really very, very informative. Thank you.
Sorry, Anita, I may have to leave a little early. So if there are any pressing questions, I can take. Otherwise,
Okay, so maybe Dr. Grover, are you there?
Yes. Yes, Anita.
Yes, sir. Would you like to comment on Dr. Santosh's presentation?
As always, an excellent presentation. He presented the entire spectrum so well that there's virtually nothing to add, except that we do see the entire range. We also see meningiomas, the primary orbital meningiomas, but also a lot of sphenoid wing meningiomas presenting with orbital involvement. And that is an additional thing that we need to look out for, and particularly when you are in a multi-speciality hospital, and those are often the cases that you need to manage. Nothing else that Santosh leaves to be added, of course.
That's true. Yeah, and Dr. Kasturi, would you like to any comment?
Excellent presentation, lots of learning points. My two questions. First question regarding the optic nerve glioma. Supposing the patient is not responding to carboplatin and any other chemotherapy, so what do you do if it keeps on progressing, but they want the eye to be retained?
Yeah.
Should we do just a debulkment?
debulking is risky. People have done it, but I don't recommend debulking unless it is a cystic degeneration. When an optic nerve glioma has cystic degeneration, it shows up very nicely on MRI. Then you can actually do either a CT assisted or a direct aspiration of the cystic content. So there is a good decompression, or you can actually go and take off the optic nerve sheath by orbitotomy approach, a nice window, so that there is a good decompression. That is the only situation where, for the sake of vision, you do a optic nerve glioma surgery. Otherwise, debulking is something that I would not be very keen on doing. You can jump to external beam radiation. If a child is not responding to chemotherapy, then EBRT is a very good option. Our radiation oncologists are comfortable giving EBRT definitely after 3 years of age. But if it is really indicated, they could even do it at a 1 year age, as long as they don't have to irradiate the pituitary area. And if a child has intracranial extension, then that becomes a big problem. But with target therapy, all the drugs are currently available in India for various other indications. These are off-label indications and you can use them. And in patient who is progressing despite chemotherapy, even in a child, bevacizumab is supposed to be useful, which is easily available. So these are some of the options that we currently have.
And what about after radiation? Is there a chance of recurrence?
Yes.
How long do we monitor them for,
Yeah.
and what are the chances of recurrence?
Right. In the area that is irradiated, there is very low chance of recurrence. But if the radiation oncologist has not taken care of the edges or the posterior extent of the lesion, that is where it's called edge recurrence or radiation, whatever the optic nerve lies outside the field of radiation. So we recommend that the radiation oncologist looks at the MRI and plans, the radiation field very well. Generally, they plan the field based on CT scan, but here CT scan will not help. MRI is mandatory.
Has to be
And
MRI.
we advise them to give at least 10 millimeter more to the extent of maximum extent that is determined on MRI as the field of radiation. So they add plus 10 millimeter to the extent that is determined on MRI for safe margins.
And
Wonderful.
what is the dose of bevacizumab?
Dose I don't remember well. I mean, of course, we can.
That's fine. Yeah. Right. So thanks a lot, Santosh. That was really very enlightening. And we were lucky to grab you for the 15 minutes we got you. So we will now move on to our next speaker. Our next speaker is Dr. Tarjini Dave. She is a senior accomplished oculoplasty and orbital surgeon from LV Prasad Eye Institute. And this is a thyroid optic neuropathy is something which all of us do face from day to day, and be interesting to hear her views on it. So, Tarjini.
Thank you so much, Dr. Sethi, and thank you, Dr. Bhattacharjee, for the invitation. Big thanks to the ARC team as well. Ruju did a fantastic start with the anatomy. I enjoyed your talk, Ruju, and I have a very tall task of following up after Rashmin and Dr. Honavar's talks, but I think I'll try to do justice. I'm going to speak on dysthyroid optic neuropathy. The way I have structured my talk is to take you through certain objectives of recognizing dysthyroid optic neuropathy before finally zooming in on the surgical treatment for dysthyroid optic neuropathy. So we'll certainly go through the pathology and clinical features, the medical management, the newer drugs that are available, and then hop, skip, and jump to the surgical management. Thyroid eye disease, as we are aware, is a very sight-threatening autoimmune disorder, which is extremely disabling, disfiguring, and affects the quality of life of the individual, especially since it has a very long temporal course. And once the disease starts, for about the next 3 or 4 years, there are several changes that come about in the patient's appearance, in the function of the eyes, and a lot of disabling sequel like strabismus, double vision, sometimes dysthyroid optic neuropathy are left back. If you were to look at the entire proportion of patients who develop thyroid eye disease, about 5 to 10% would go on to develop dysthyroid optic neuropathy. And there are two mechanisms by which the optic nerve sort of gets compressed in dysthyroid optic neuropathy. The commonest cause is enlargement of the extraocular muscles. So if you look at the apical cuts on a coronal scan, you'll see that that's the optic nerve, the superior, the inferior, the medial, and the lateral rectus. And you see a good amount of intracornal fat around the optic nerve. In a patient who has thyroid eye disease, because of the swelling up of the muscles, you can see that the intracornal fat sort of reduces, and those thickened muscles are now almost touching the optic nerve. If you look at coronal scans further posterior, you'll see that in most of these patients, the superior, medial, and inferior rectus are pretty large, and there is absolutely no intracornal fat space around the optic nerve in these quadrants, and that is what produces compression on the optic nerve. The smaller theory here is also of stretch neuropathy. We all know that optic nerve is resilient and it has a sinusoidal course in the orbit. But in thyroid eye disease, because there is accumulation of fat and the muscles swell up, there is proptosis, sometimes extreme proptosis, and that extreme proptosis produces a stretch on the optic nerve. The otherwise sinusoidal optic nerve now stretches, and that produces stretch neuropathy. That's a smaller cause of compressive optic neuropathy within the spectrum of thyroid eye disease. Now, here's one such patient. I just wanted to bring out a clinical situation. You can see the proptosis and all the telltale eyelid signs and congestion of thyroid eye disease in this gentleman. And you'd expect to see a scan where muscles are thickened. But no, this is what has happened in this gentleman. You can see that the eyeballs are beyond, way beyond the line that joins the anterior part of the zygoma. Normally, the eyeballs, if you draw this line through the zygoma, it goes through the center of the eyeball. So there's extreme proptosis from increase in the intracornal and the extracornal fat space, very little muscle thickening, but it's this extreme proptosis which has produced stretch neuropathy in his case, and he actually had disc edema, less on the right, more on the left side, possibly because the left also has a thickened extraocular muscle which is compressing on the optic nerve, and because of both these factors he had this thyroid optic neuropathy. Now, what are the risk factors? advancing age, and diabetes are the two factors that will worsen the chance of a patient with thyroid eye disease developing dysthyroid optic neuropathy. Males have a greater risk of developing this. Smoking is the only adjustable or modifiable risk factor, and treatment with radioiodine can sometimes push a patient into aggravated thyroid eye disease as well as dysthyroid optic neuropathy. Clinical features which are classic of thyroid eye disease obviously will be present in these patients. In India, you see a lot of thyroid eye disease patients who otherwise don't have the classic inflammation and are called as the silent thyroid eye disease patients, but you typically tend to see the eyelid signs and proptosis in these patients. Besides this, the features that you will see in dysthyroid optic neuropathy would be vision. That's the most important thing. And in vision, a drop in color vision is very, very sensitive for picking up dysthyroid optic neuropathy. Of course, you'll be able to catch a relative afferent pupillary defect if the pathology is only unilateral. If the patient has dysthyroid optic neuropathy on both the sides, it may be difficult to pick it up. Visual field defects are very classic in dysthyroid optic neuropathy, and they begin with enlargement of the blind spot. And typically, you tend to see inferior altitudinal defects in these patients, which will be progressive over a period of time if not treated. Optic disc edema is something which is seen in only 20% of patients and is a sign which is the least that you see in clinical examination of these patients. You'll obviously find an altered VEP as well as OCT. You'll have increased latency and decreased amplitude on visual evoked potential. And on OCT, you'll see generalized thinning of both the retinal nerve fiber layer as well as the ganglion cell complex. There are certain advanced MRI functions which can help you predict several structural changes within the optic nerve as well as the brain. And you have certain metabolic and diffusion markers on MRI which will actually help quantify the amount of optic neuropathy that the patient has. Obviously, these are not all available for patient examination at this point of time, but these are certain things that we should look forward to. When you have to manage these patients, the first line of treatment for sight-threatening thyroid eye disease is high-dose methylprednisolone injections. And if these are suboptimal, you immediately progress to performing an urgent orbital decompression to preserve the vision. So what's the protocol that has been put forward for sight-threatening disease? This is 1 gram daily for 3 days. This can be given as 1 gram bolus or 500 milligram BD or 250 milligram QID, but essentially a gram per day for 3 days. Repeat it after a week. And if the patient after a couple of weeks is still having clinical features of dysthyroid optic neuropathy, move on to the next line of treatment. And we look at certain case examples. So here's a gentleman who has the florid inflammatory type of thyroid eye disease with dysthyroid optic neuropathy. And this is him treated with steroid. You can see that the inflammatory signs go down. The vision may improve at this stage. And if it does, you follow this patient up with the same protocol after a week and then tapering oral steroids. There are sometimes patients who come to you with an eye that may not look very inflamed, but still has dysthyroid optic neuropathy, where at times giving IV steroid might become challenging. For example, this was a patient with bilateral dysthyroid optic neuropathy. He was post-renal transplant. He had only one functioning kidney. He was diabetic. His creatinine was 5.6. He had no GA fitness. He also had pyelonephritis at the time of presentation. So IV steroids were out and decompression was out because there was no fitness for general anesthesia at that point of time. So what did we do? At presentation, we injected 1 ml of Kenacort, 40 milligrams of Kenacort into the orbit, inferior lateral quadrant of the orbit on both the sides. This was him after the Kennicott injection. He's developed a little bit of esotropia, but you can see the caruncular edema and congestion has actually gone down. The eyelid edema has also gone down. And we bought time over which his systemic parameters were controlled and eventually performed an orbital decompression. Though he has esotropia, we've been able to salvage his vision. Now, what do you do when steroids alone don't work? Or say, for example, steroids are contraindicated in a patient. The drugs that are available in our repertoire at this point of time are rituximab and tocilizumab. Teprotumumab is not available in India at this point of time. Between these two drugs, tocilizumab certainly has an edge in controlling the inflammation of thyroid eye disease. This is a patient of thyroid eye disease with the edema that you see. It's subtle, but you certainly can see eyelid edema, a little bit of chemosis and congestion and proptosis more on the right side. He had dysthyroid optic neuropathy. This is him after infusions of tocilizumab. He did not get any IVMP. It was purely tocilizumab that he received. The dose can be either as IV injections or as subcutaneous dosing every fortnight, and about 8 to 10 infusions are typically planned for these patients. He had a reduction in inflammation, and also we were able to preserve his sight. One of the other emerging treatment options, or rather established treatment options, is to perform orbital radiation for patients with thyroid eye disease who also have dysthyroid optic neuropathy. And there is this paper by Mike Kazim and group, which has said that orbital radiotherapy has shown to avoid orbital decompression in up to 94% of cases who have dysthyroid optic neuropathy. However, there's a lack of level 1 evidence to support its use in DAWN. And again, those who are diabetic, again, there is a contraindication to the use of orbital radiotherapy. What happens when all these treatment options fail? Well, the holy grail here is orbital decompression. And what exactly are you trying to achieve? You're trying to change the shape of the orbit in orbital decompression by targeting the sinuses and the lateral orbital wall, and essentially widen the orbit or widen the cone of an ice cream so that the dollop of ice cream or the eyeball can actually sit back inside, reduce the proptosis, and the compression on the optic nerve can be relieved. So here's a lady who's had bilateral severe thyroid eye disease. As you see, this is her post 2 sessions of 3 grams of IVMP, and 1 week post that she continued to have a reduction in her color vision, and she continued to have dysthyroid optic neuropathy, which was not well controlled. And therefore, we performed orbital decompression sequentially for the left eye and the right eye. You can see that some congestion persists, but the edema, the inflammation has come down, and her vision came back to 20/20. Now, what are the walls that you target when you want to decompress? Essentially, in dysthyroid optic neuropathy, you want to free the nerve of compression. And what are the muscles which are largely involved? It's the medial rectus and the inferior rectus, sometimes the superior rectus, which is involved. And therefore, it makes perfect sense to actually perform an unbalanced orbital decompression. So what's an unbalanced decompression? Unbalanced is when you're removing two walls which are not opposite each other. So it would be, say, for example, the medial wall and floor would make it an unbalanced orbital decompression. And you can see that that is what has been performed for this lady, where the medial wall as well as the floor have been decompressed. The orbit is certainly more roomy now, and the muscles have actually moved away from the optic nerve, as you see in this lady. Versus this, if you were performing a cosmetic orbital decompression, you'd then think of balanced orbital decompression, which is the two walls which are exactly opposite each other, say the medial and the lateral are decompressed, so that the visual axis within the orbit does not change. And with a balanced orbital decompression, there's lesser risk of new onset diplopia that you are going to iatrogenically induce in these patients. However, like I mentioned in this thyroid optic neuropathy, going for an unbalanced orbital decompression is obviously advantageous. You can use incisions which are hidden, like you can use the inferior transconjunctival incision that can go on top of the periosteum and then into the orbit, or straight from the inferior transconjunctival incision into the orbit. You can use incisions which are subciliary to kind of open up the lateral wall if you also want to decompress the lateral wall in a patient who has dysthyroid optic neuropathy. And you can go via the caruncle to decompress the medial wall of the orbit. All these three incisions make it a very aesthetic surgery where you don't really need to go in and have give the patient scars. I've just shown a small model here on clay of how you approach. You can actually do a little swinging eyelid if the orbit is very tense, because these patients tend to have a lot of resistance to retropulsion because of the pathology itself. Take a transconjunctival incision in the orbit, reach the orbital rim, lift up the periosteum as is being done over here. In thyroid eye disease, you want to decompress the floor largely in the inferomedial zone. So you'll have to certainly expose the bone in that region. You can see that the periosteum is being reflected here. And once you lift up the periosteum, you land yourself on the floor of the orbit. You want to visualize and figure out where the neurovascular bundle is and keep it preserved and not damage it. You can use several instruments like a malleable and a lens spatula in a hand-over-hand fashion and expose the floor. You can use retractors to take the fat away so that you have clear visualization of the floor and the neurovascular bundle, and then go ahead and decompress the floor. Similarly, for the medial orbit, you can split the caruncle and go via the caruncle posterior to the lacrimal sac and open up the medial wall of the orbit, again in a hand-over-hand fashion, and kind of reach the medial wall of the orbit. I'll show you this on a patient. So here's the transcaruncular incision. This is the caruncle. This is the upper eyelid and the lower eyelid. This is superior extension and inferior extension of the incision. Once you've split the caruncle, you enter posterior to the posterior lacrimal crest and then go ahead and expose the medial wall of the orbit. Decompression is a very difficult surgery to record. Surgeon himself or herself sometimes is struggling to visualize. And what I've tried to do over here is to use a microscope through which you're seeing the medial orbital wall now. You break open the medial orbital wall. Typically, you do it from below the ethmoid foramen till the part where the medial wall meets the floor. And you can use rounders or just a suction or any other instrument. This bone is very thin, easily pliable, and can be removed. You can, if you come across a lot of bleeding, you can actually strip off the ethmoid mucosa. Mucosa is a source of bleeding. Stripping it off kind of improves your visualization. And then you can open up the periorbital fat and let the fat as well as the muscles prolapse towards the ethmoid sinus. I'm just adding a little bit of medial fat decompression over here. Once you're done with the medial wall decompression, you can actually move on to the floor decompression. Here, this is still medial wall where I'm going posterior, almost till the posterior ethmoid. Now, here's the extension of that caruncular incision inferiorly and then entering the inferior orbit. Like I showed in that little sort of, animation, you use hand-over-hand maneuver to expose the orbital floor, and then you decompress your orbit largely in the inferomedial part. You preserve the neurovascular bundle here and decompress the inferomedial region of the floor so that again the inferior rectus moves away from the optic nerve. For the interest of time, I'll skip the lateral wall part. Here are certain patients who've undergone an unbalanced decompression, pre-op radiology, post-op radiology, showing the muscles prolapsing into the respective sinuses and more space for the optic nerve to breathe. For some reason, the squint also improved in this patient after an orbital decompression. Now, a word of caution when you decompress the medial wall. You have to localize where the skull base is. And how do you localize the skull base? So go look for the crista galli. What you see next to the crista galli are the cribriform plates. And what you see over here is the fovea ethmoidalis. This forms the skull base. If while decompressing the medial wall, you end up hitting this bone or traumatizing it, you'll have 1, CSF leak, and 2, air go up into the brain, which can produce what is known as pneumocephalus. So analyzing your skull base preoperatively is very important. You'll have patients who have a high skull base or a low skull base, and visually just looking at the medial wall and seeing at what level the skull base is will give you an idea. So if your skull base is along the middle part of your medial wall, that means it's a really, really low skull base. And be very careful when you're producing decompression of this bone that you're not hitting the fovea ethmoidalis and traumatizing it and producing a complication like this, which is air going into the brain and giving you the Mount Fuji sign. This can lead to coning and death on table. The other complications of orbital decompression obviously include new onset diplopia, largely because of the asymmetric position of the eyeball within the orbit. Now, the orbital axis and the visual axis may not be aligned. Obviously, you may have some under or overcorrection, and bleeding and infection remain common risks. These are patients they've had active thyroid eye disease, they've undergone an orbital decompression. Both of them have different grades of esotropia. One we were able to manage with the help of prisms, and the other we could not manage with prisms and required corrective strabismus surgery at a later point of time. Where are we headed? We are headed towards looking at biomarkers, probably looking at tears and looking at tear proteomics to figure out what patients with thyroid eye disease are likely to develop dysthyroid optic neuropathy, to look at the blood as a biomarker and say which and prognosticate which patients are going to develop dysthyroid optic neuropathy. We can look at models of thyroid eye disease. Animal models are very difficult to make. We can make a fibroblast model and look at what is it that is possible, what is happening in terms of the downstream inflammatory markers that are produced in these different phenotypes of the disease, and try and target it with targeted therapy, gut microbiome, as well as gene modulation and precision medicine in treating these conditions is probably where thyroid eye disease is headed. To conclude, I've spoken to you about dysthyroid optic neuropathy that can occur in 5 to 10% of patients with thyroid eye disease. Color vision loss is the first marker and is very sensitive for picking up dysthyroid optic neuropathy. Patients can have 20/20 vision, but loss of color vision and dysthyroid optic neuropathy. Steroids, IVMP, high-dose protocol remains the mainstay. Tocilizumab is a biological agent that can come to rescue. Radiotherapy has a limited role. Surgical decompression is required in most patients and largely is unbalanced. A good look at radiology and good knowledge of complications is required before you delve into these surgeries. Thank you so much.
Thank you, Dr. Tarjani. That was a very wonderfully you've covered the whole topic, really covered it very nicely. I think we don't have too much time. I can just ask Dr. Grover, since he just shared with us the statement from the WSOPRS. Dr. Grover, are you there?
Yeah. So I'll just say a few words about what is changing and what is the current literature pointing to. One, of course, we know that it tends to occur more often in males and more often in middle age, and that smoking is a bad factor predisposing to it. The management trends are changing. There is much lesser emphasis on IV methylprednisolone being given in heavy doses, like a 1 gram dose for 3 days and so on and so forth. It's realized that that probably does not work as well, and it has disproportionate side effects. So the trend is shifting towards maybe just about 500 milligram, maybe even just alternate day, and trying out the medical therapy. And there is a much greater realization that most patients would need surgical rather than medical management when there is a dysthyroid optic neuropathy. And there is an increasing trend towards looking at that. Amongst the medical therapy, Tarjani spoke about radiotherapy. So where radiotherapy is available, that trial about radiotherapy with oral steroids alone is also one of the frontline management protocols that are now followed. Number two, tocilizumab that Tarjani spoke about, it has been realized that in the two trials that there are, it worked well only in the one where it was used in earlier stages of the disease. So it works
best only in acute stages. So maybe it's a good choice in this thyroid optic neuropathy. For teprotumumab, there were studies which said that it works in acute stage as well, but it is realized that the recurrences are very high. And of course, side effects are being increasingly spoken about. So teprotumumab is not yet accepted as a management protocol in this thyroid optic neuropathy. As for the decompression, she's spoken beautifully, presented beautifully, wonderful. The things that are being emphasized are that infromedial and medial wall is one very good option. And in the infromedial one, the sacrifice of the posterior part of the infromedial strut and reaching right up to the posterior ledge to take care of the palatine bone by the infromedial approach is a very good choice besides medial wall. But sacrifice of the posterior part of the ledge is important, of the infromedial ledge, if you want to get a good decompression. On the medial side, wonderful. She showed a beautiful video. It's very difficult to get that. One caution sometimes we do need is being a little more conservative with opening periorbita on the medial side, because that tends to lead much more often to diplopia. So maybe or use it or open it only away from the center, maybe a little superior or inferior, so that you tend to have less diplopia. So in the decompression, you can also use this deep sphenoid or posterior sphenoid to get close to the optic nerve. That approach is also used, but much more often would be infromedial and medial wall approach. All in all, I think Tarjini covered it beautifully. She covered all aspects. Just one emphasis, increasingly talking of surgery rather than medicine, less stress on intensive and other options like tocilizumab, radiotherapy also to be considered.
Thank you, Dr. Grover, for summing it up very nicely. And yes, I must compliment you, Tarjini, both on the videos, and I really liked your model-based animations that you showed. That was also very nicely demonstrated. So we now go on to the next speaker.
I'll just add one point to it. I totally agree with Grover, sir. Very recently, we were in the SOE meeting, sir. And so there was a big session on thyroid and lots of discussion. Many new points were discussed. But the conclusion, what they have mentioned, that the surgery is still the best option. And most importantly, it is the responsibility of all oculoplastic surgeon to do the correct surgery and to teach the next generation there. So that was really highlighted. Then are we doing the correct surgery? And if yes, then that is the best option. So this was from the European group of doctors. And even I feel so much of we keep on trying medically, ultimately it keeps on recurring. So I also agree, and thanks, Tarjini, for the beautiful videos that you have shown.
And with surgery also, you combine it with steroids before surgery.
Okay, so we now invite Dr. Kasturi for her talk. And Dr. Kasturi is an amazing surgeon and always has such lovely teaching points in all her presentations. So we look forward to hearing from you, Kasturi.
Okay, let me share my slides. Okay. So thank you very much, and especially thank you, Anita, for moderating this session so well. Wait, I cannot. Can you see my slide?
Yes.
Just
do full screen.
How do I do the full screen? It is
Here
not...
at the bottom, right at the bottom. Yeah, there. Yeah, that's it.
I can't see my system. Wait, it is not seen in my system. Or can I do something over here? Wait. Okay.
Go to the slideshow.
Okay.
You can
so then
play from start.
Yeah.
Play from start. Okay.
Yeah.
You continue to share. Okay. So I'll be speaking on optic canal decompression for traumatic optic neuropathy with the theme when to observe and when to intervene. So I have no financial disclosure in any of this presentation. Only thing I'd like to mention, thanks Ruju for the wonderful anatomy that you have shown, mentioning all the 4 parts of the optic nerve. And what I want to insist today is, yes, the narrowest part of the optic nerve is the intracanalicular portion. And this is the most common site for the traumatic optic neuropathy. So when we talk about optic canal decompression in traumatic optic neuropathy, but what it has, made all of us realize that till today it remains controversial because of the lack of the large-scale randomized clinical trials. And however, there are several consensus guidelines which have emerged based on the available evidence, expert opinions, and the clinical experience. So the main key consensus guidelines for the management of TON is that we need to do a thorough evaluation of the optic nerve in terms of the visual acuity, in terms of the color vision, visual fields at the pupil. Steroid is definitely the treatment of choice, but there are so many studies which have shown that steroid itself can lead to loss of complication, and then comes the surgical decompression. However, the other school of thought is that we can go for conservative management, or we can have a multidisciplinary approach, take the help of the neurologist, the neurosurgeon, neuro-ophthalmologist, and then go for the final visual rehabilitation. So till date, there are no clear guidelines available in the literature for the optimum management of the traumatic optic neuropathy, wherein majority of it are managed with customized or tailored approach. Most publication had stated, especially the IONTS study, which concluded that neither steroid nor the canal decompression should be considered the standard of care for patients with traumatic optic neuropathy, and that every ophthalmologist should decide to treat or not treat on an individual basis. However, there are other studies by Chow et al., which is a very nice study on 58 patients who concluded that surgery and steroids should be given in all patients with traumatic optic neuropathy. And the largest study of 400 cases by Fukado, who has shown that the best results, whether it's a direct, especially in cases of indirect on, it is optic canal decompression. So when we talk about the treatment, we know one is a megadose of steroid and other is the surgical optic canal decompression. And as mentioned by Dr. Ruju and also Tarjani, I feel that when we go to the optic epics, we should use some guidance, which is usually a GPS system. This can be done both. This is one of our patient only where we are initially doing endonasally, and also it can be also done by neurosurgeon, which is a more major surgery. But both this surgery, whether we do endonasally or by a neurosurgical approach, it has got lots of complication in terms of carotid artery. Like if you look very clearly, just below the optic nerve, this is the optic nerve, lies the opticocarotid recess. So the chance of injuring the carotid artery is very high. So what is the guidelines? They say that we can tell the patient that we can do nothing and hope that the vision will improve. Just observe the patient, or we can either do something and also hope that the vision can improve. Either we give them with steroids and other neuromodulators, or we can go for the surgery. So what is our approach? Our approach is very simple. It's an orbital approach where we go by a very minimally invasive surgery, that is a transcaruncular approach. So the question is, why do I prefer this orbital approach? If we really look to the anatomy, how the ophthalmic artery comes from the internal carotid artery, you see that it comes from medial to the lateral wall of the orbit. So any procedure in the medial wall of the orbit, as you can see how the artery moves it, it is much safer and less chance of injuring the optic artery. Secondly, if we look to the canal Ruju has very nicely mentioned, is a small area, 5 to 9 millimeter. So when you look to the canal, there's one orbital part and one that is a cranial part. So the average diameter of the cranial part is much wider, almost double that of the orbital part, which is approximately 7 to 8 millimeter. And the orbital entry is, orbital point is only 4 millimeter. So most of the strangulation occurs in the orbital component of the canal. So we need to, even if we release this orbital part, so the whole of the canal opens it, because the strangulation does not, or any of the compression does not occur in the cranial, it is more in the orbital part. So when we look to this canal, this small 5 to 9 millimeter of the canal, so either a direct injury by a fractured segment or an indirect either by hematoma or the shearing of the bile vessels can lead to a traumatic optic neuropathy, which is considered as one of the ophthalmic emergency. And the second question I would like to mention is supraorbital fissure, and the small opening is the optic canal. So even if we remove this part of the sphenoid bone, so this will open up the whole of the canal, and approximately the shape which we know how the shape of the optic canal, narrow at the orbit and widen in the cranial part. So if we can widen up this orbital part, then it also leads to a very good decompression. And definitely navigation must be used because it is a GPS system which helps us to reach the destination with precision and accuracy, which is very important, especially when we do any surgery within the apex, because we know the internal carotid artery, which lies just lateral to the supraorbital fissure and the optic canal. So you should be very careful when we go to the apex, any surgery in the apex, whether it is a trauma or a tumor, one should usually use a navigation system to be a more safe surgery. So this system, what we do a registration, we create the electromagnetic field, we create the whole pathway of the operation. Like this will really navigate. Can you see this is a canal? So once I'm putting my stylet, you can see it is showing that I can move from the orbital to the cranial, and this is the video after doing the decompression. Since we have decompressed the canal, we can see the very nicely the whole of the stylet moves from the orbital to the cranial, showing that the whole of the optic canal has been decompressed. So, and secondly, when we in the navigation system, like you can look to the whole of the brain or the base of the skull in a very nice way. You can have a 3D view. You can also have an endoscopic view nowadays, where they give you the actual measurement. In some textbook, it is written the canal is 6 millimeter, some it is written 9, and also some says 1.1 centimeter. So we should know the exact length of the canal before we touch it, so that we don't enter intracranially and lead to injury to the intracranial structure. And thus, this is the first case report which we have done of 2 cases very initially, way back in 2018, when we have started this navigation-guided optic canal decompression for the traumatic optic neuropathy. So this is a small surgery I'm showing. If you really look into it in the actual, you can see this is a superior orbital fissure, this is the optic canal, and you can see a fractured segment impinging on the canal, and there is a fracture of the superior medial wall on the right side of the optic canal. So this is a situation since you have seen a bony segment impinging on the optic nerve. So in such situation, we can go for a decompression. And you can also see this is how after the registration, the whole of the pathway has been drawn where the end point of a target, and you can mark the target before you start with the surgery. And this is how you can see a small bony segment. This is the small bony segment impinging. And then once we do the registration, we go ahead with the surgery. So we make a transcaruncular incision, and then once we go through it, what we get approximately 24-25 millimeter deep inside the orbit, we get the anterior ethmoidal blood vessels and the nerve. So the blood vessels we cauterize, we go further down till we reach the posterior ethmoidal blood vessels. But we usually do not cauterize the posterior ethmoidal blood vessels because just below it lies the optic canal. So here I'm putting this navigation stylet, and this will show me where exactly, whether I'm in the anterior ethmoid. Here it is showing I'm much towards the posterior ethmoid. I need to further go down. In the same direction you go down, and this is what you see. You reach the canal where you see the Y-shaped annulus of zinc. Now you're sure that you have reached the canal. So even if you just remove this entrance of this canal, it just opens up into your the sphenoid sinus, and this gives a very good decompression. As you can see here, this is an endoscopic view which comes with a navigation system. It actually guides you. You also get on the table real-time endoscopic view. Like you can see the superior orbital fissure, how it looks. And then once you go further, more medially and posteriorly, it will show you whether you have reached the canal. So what I do, I punch up this superior medial part of the canal, and then I proceed, I remove some of the bony segments. Still you see this whitish layer, and this is the optic nerve. So once you see the optic nerve, you again put your stylus, see whether you have reached the targeted area that you have already marked it, and whether you have gone for the full decompression. So it's quite a minimally invasive surgery. Only thing that you need something to guide you during this procedure. Another patient where you can see a bony segment impinging on the nerve. So such patient do a decompression, and you can see definitely improvement. In fact, 12 days we usually do not see much change in the amplitude, but usually we see the change in the latency. And also the OCT pictures are much better before and after the procedure, including the ganglion cell analysis. When another cause is when you have a hematoma. If you look here, there is a hematoma out here. So here also you need to do the surgery. Surgery because now you have a hematoma impinging on the optic nerve. So same procedure, you keep on compressing the canal. After you see the annulus of the zinc, put the stylus, see whether you're in the correct plane. Since you are still in the posterior ethmoid, way to go to the optic canal, then you remove whatever the fracture segment is. Once you remove the fractured segment from this canal area, you have to see the optic nerve. So once you see this white sheet of the optic nerve along with the annulus and the zinc, and we have already measured where exactly is the hematoma, with an MVR blade, we just make an opening within the sheet of this optic nerve sheet, and you can see the blood is being drained off, and then this blood is being drained off. You can do a good decompression followed by a IVMP steroid. And you can see that definitely the edema is much reduced after the procedure. And you can see here how this improvement of the VP, this is just before the procedure. Even within a month's time, you see such an improvement of the VP. And after a year, you can see much better in terms of both the latency and the amplitude. So these are another few of the patients we are following the surgery. Even the person who had done it before the surgery, you can see almost extinguished VP, but later you can see the VP has been much reduced following the surgery. So we have done more number of cases. We had gone up to almost more than 80 cases, but we have reported some of our 52 cases out here in this British Journal of Ophthalmology, where we have mentioned that it is one of the good treatment for conditions like indirect traumatic optic neuropathy. So what was already known, like on this topic, we knew that the surgical domain for the optic canal decompression overlaps with various disciplines ranging from transcranial to transnasal with no standardized pure ophthalmological approach. And secondly, we also know that the optic canal decompression directly targets the optic nerve within a compact optic canal, yet there is substantial uncertainty in the existing literature regarding its effectiveness in treating the TON. But what is new in this study has shown that the navigation system provides better localization and precision during an optic canal decompression. And also this study for the first time has enlightened the role of anatomical factors like optic canal configuration, like especially the Lanos type of the optic canal, and the presence of ONOD cells as predictive factors in prognosticating the surgical outcome of the optic canal decompression. So what this study have shown that those patients who have the Delanos type 3, like you can see this is almost a type 4 Delano optic nerve where you see the whole of the nerve is within the sphenoid sinus. So those patients having type 3 or type 4 optic nerve, or those patients who have the ONOD cells, they are at the much risk of injury to the nerve during the surgery, and these are the patients who gives real poor prognosis following a surgical decompression. And also those with a very hypoplastic optic canal, the chances of recovery is very less. And the most important, which I have also learned, that if you look to, like this is my superior orbital fissure out here, and if you look here, this is the superior orbital fissure, and here somewhere there is the optic canal. So we see that this is the internal carotid artery which lies something lateral to it. So any fracture in the superior lateral part of the canal, basically even if you see a fracture, we should not be aggressive and go and chasing the fracture segment, because there are reports where this fracture segment, it keeps on impinging on the internal carotid artery. So the moment you remove this fracture segment, there can be a severe bleed from the internal carotid and a loss of life. So when to observe in traumatic optic neuropathy? Yes, mild to moderate vision loss with stable or improving vision. No radiological evidence of a canal fracture or a decompression. When a patient presents very late to us, there is no potential for any surgical benefit. Patient is otherwise unfit for the surgery. Visual loss due to indirect trauma without any mechanical compression, and there is a good recovery within the first 2 days. And when the patient does not give any consent for the surgery, these are the situations where we observe in cases of TON. And the approach should be, we should closely monitor the vision and the pupil, and also continue with the steroid if within the treatment window with serial imaging. But when to operate when there's a rapid or progressive vision loss unresponsive to steroid, radiological evidence of bony impingement of optic canal, or there's a hematoma or orbital apex compression, complete vision loss with structural compression and poor recovery for poor potential for recovery, no improvement after 3 days of medical therapy. When they're present in the early part, though I have operated up to 1 month, I usually do not touch after, if the patient comes to me after 1 month, and usually young patients do much better. And the approach should be, the goal is to basically to relieve the compression, to restore the perfusion, and to prevent secondary damage. So with this, I conclude that the current guidelines for managing TON emphasizes the importance of a tailored case-by-case approach. Steroid and surgery remains an option, though the decision to use them should involve patient-centered discussion due to the lack of clear evidence. So close monitoring and a good team is essential for the optimal patient outcome. Thank you very much for a patient hearing.
Thank you, Dr. Kasturi, for that excellent demonstration of management, surgical, especially the surgical videos were really excellent, excellent management of TON. I am going to apologize to Dr. Mukesh Sharma. I somehow I got the order wrong. I think we'll go on to Dr. Mukesh, and then maybe we can discuss after because there's still 3 more speakers. So I'm going to invite Dr. Mukesh Sharma. He is a very accomplished oculoplastic and orbital surgeon from Jaipur. He is heading Center for Sight. And he's going to tell us about in idiopathic intracranial hypertension, how to make the patient better by relieving the strangulation. Okay, Mukesh. And again, I apologize for getting the order wrong.
No, we keep the best for the last.
That's what I told him. Yeah.
I don't think we can hear, sir.
Mukesh, we can't hear you. Are you speaking? Unmute yourself.
Yeah.
We can see your slides, but we can't hear you.
Yeah.
Yeah, now
we can hear you now. Yeah. Okay,
fine.
cool.
So at the outset, I'm thankful to Kasturi and whole team ARC for having me here in this wonderful symposium on optic nerve pathologies and various procedures. And also I'm thankful for Dr. Anita for inviting me here and also moderating the session so well. So it's not moving. Okay. So optic nerve sheath fenestration is not at all a difficult entity, not at all a difficult procedure, but only thing is that you do need to control your coronaries, because one always gets some tachycardia whenever you are placing your knife over the optic nerve, and also when you check visual acuity on the second day when patient comes back to you and your heart is in your mouth, whether patient is able to read at least the pre-op vision or not. So we all know about IIH. This is a condition wherein there is raised ICT of unknown cause, and most patients, they have papilledema. Headache is the most common symptom in these patients, and it is aggravated by Valsalva maneuver, and it's more in early morning. Patient do get nausea, vomiting, etc., tinnitus. So these are the neurological symptoms, and these symptoms, they are not an indication for optic nerve sheath fenestration. Predominantly these symptoms are indication for shunt. But if patient gets visual symptoms like transient obscuration of vision, which is more so in orthostatic position, and visual loss, which is the major morbidity, visual field defect of any time, which is there in 90% of cases, and diplopia. So there are certain etiological factors for this particular condition. There are drugs, vitamin A, steroid, oral contraceptive is an important factor, and then there may be other systemic condition which can lead to IIH. So I come to the management part of IIH. Initially, we try to manage patient conservatively, try to do things like weight loss, lifestyle modification, discontinuation of offending agent, etc. Oral Diamox is always given to lower the ICT along with other measures. But if patient is not able to tolerate medical therapy, and if this conservative treatment is not able to prevent the progressive vision loss, then we have to go for surgical treatment, which is in form of optic nerve sheath fenestration. CSF shunting can be done for vision loss also, but ideally optic nerve sheath fenestration is the primary mode of surgical treatment for vision loss, and CSF shunting is there for other neurological symptoms like headache and other things. So there are various approaches for optic nerve sheath fenestration: medial approach, lateral orbitotomy approach, lid crease approach, transantral approach, and then there may be other CSF shunting procedure. I always do medial approach, transconjunctival medial approach. I'll be showing you. So CSF shunting for visual symptoms is not at all an attractive proposition. If you compare all these ophthalmic approaches, medial transconjunctival, lid crease approach, or lateral orbitotomic approach, the shortest surgical course from incision to nerve is there in medial transconjunctival approach. Only thing is you need to detach medial rectus and then reinsert it. So sometime it may be of some problem, but generally it's a fairly simple surgery. There are certain contraindication also for this particular surgery. As I told you, if patient is not having visual symptom, headache and other neurological symptoms are there, then obviously shunt procedures are better procedure. If patient is on chronic anticoagulants, then you have to really control patient well before taking up for surgery, and you do get these cases because sometimes there are patients with dural sinus thrombosis, etc., and you need to do this surgery also. Obviously, if active infection is there, then you do not do it. So I'll be showing you a few of the surgical clips. So this is medial transconjunctival approach. You do peritomy medially, hook the medial rectus, tag it with 6-0 vicryl and disinsert it. So once you have tagged it and disinserted the medial rectus, then secure it medially with the help of some artery clamp and all, and then pass holding suture, traction suture at the insertion site of medial rectus so that you can retract the globe laterally. Obviously, you need to protect the corneas. So once you have done that, you place your retractor inside and just identify the optic nerve. This is the optic nerve and avascular area. I have applied MVR knife there, and you can see gush of CSF which is coming out through that opening. So let the CSF come out. You can see this emulsified kind of liquid, fat, globule, things like that. This is very typical of CSF appearance. So then once your CSF is out, sometimes fat also tend to obscure your field, then again retract back the fat. I am infiltrating this area with Vigamox and see the fat globule coming out of the CSF. Then you resect out a piece of sheath also and your surgery is done. So just reinsert the medial rectus again. So it's a fairly simple surgery, and but generally I do it under general anesthesia because obviously you do not want to lose one pupil. There is transient enlargement of pupil in many of the cases, but this pupil will become normal. This has almost become normal at the end of surgery. Initially, it was more enlarged. So, like sometime, if optic nerve sheath is quite distended, then you can have a great visible kind of optic nerve sheath and optic nerve. In this particular patient, the optic nerve sheath was distended. So everything was done under perfect visualization. So this sheath block is being resected. Underneath, you are seeing the optic nerve trunk. So typically, we do not put these patients on Diamox before the surgery. We try to stop Diamox. We want little bit of high pressure so that CSF comes out and your optic nerve sheath is distended before taking a patient for surgery. So these are some of the pictures. This is patient preoperatively chronic optic atrophy due to IIH, long-standing IIH. This is after, I think, post of 6 weeks. And this is the field which has come back. Initially, this patient was only PLPR, but after surgery, this field has come back. Yet another patient, this is 6 week post-op. You can see papilledema is grossly reduced. And this is 2 month post-op. It takes long time for papilledema to completely go away because of exoplasmic swelling which has occurred due to long-standing papilledema. But after 2 months, you can see a gross reduction in the papilledema. And this is again after 2 weeks. You can see hemorrhages and everything has reduced. And this swelling has also reduced a lot. So, so we have done like we are doing it routinely. And when you talk about the complications of this particular procedure, then vision loss obviously can be a major problem, and it can be due to direct trauma to optic nerve. This is relatively rarer. More common cause of vision loss is damage to ciliary artery or to central retinal artery. So typically we remain there between 2 to 10 millimeter from eyeball on to the optic nerve. So this is typically an avascular zone, and arteries are not there in that zone. Then you can create globe perforation because you work into the tiny area, so you have to be really careful. Then there may be other minor problems also. BRAO and CRAO, sometimes you may get these problems. So considering that vision loss is not a very common complication and other are minor problems, optic nerve sheath is an attractive option. This is a relatively older presentation. We have done this now in more than 50 patients. We have presented this in IJ also. So when we have done this in 3 patients with no PL to PL only vision. And out of these 3, 2 patients has gained vision significantly. So this is about those 3 patients who had very less vision and they gained 2 of them, like one gained 624 from PL negative vision and the other 612. So these were patients with recent loss of vision and they can get vision. So to conclude, we advocate optic nerve sheath fenestration for all IIH patients with some field defect. Our threshold is any field defect with IIH, we take a patient for surgery. Initially, we were taking a patient with loss of central vision, like if patient has become 612, 624 or poorer than 612 vision. But now we operate even in 6/6 vision with some field defect. Patient can get vision gain even in complete vision loss also, because some viable fiber may exist and they may gain functionality. But if optic atrophy is chronic, permanent, then there is obviously very less chances of any vision gain. Or to our fortune, we only complication which we got is transient pupillary atony in our initial 50 cases. But after that, in 2 cases, we had reduction in the vision from preoperative vision. And that was due to some arterial supply obstruction. So one patient had reduction from 624 to 660 vision in post-operative vision period. And another one, I think, had reduction from 69 to maybe 618 vision or so. So these are our references. Thank you. Thank you for your patience hearing.
Thank you, Dr. Mukesh. That is a really
I think now we'll go for the cases.
yeah.
I'll just add, I totally agree with Mukesh. It is a very rewarding surgery. And I would say one of the most rewarding cases in my life was a case I did 3 weeks ago. This was a young male, 24 years of age, and he was documented as having disc edema for 3 months or so. His visual acuity recorded 3 days before I saw him was 6.9, 6.12. And on the day we saw, it was PL, both eyes, PR inaccurate in 3 quadrants in one eye, and PR accurate in the other eye with just counting fingers. And this was a fulminant IIH, which occurs in about 2% of the cases. So we decided that we had to decompress him, and we did it in emergency. So next morning we did it on Sunday morning. And after a bilateral optic nerve sheath fenestration, 2 weeks down the line, his disc edema is gone. He's seeing 6.9 in one eye, 6.12 in one eye, and this is a 24 years old male. His field has already widened, and most rewarding for somebody who was losing vision so rapidly. So we decided to do it bilaterally because we thought we can't take any chances in this, and it had to be done rapidly because in fulminant IIH, you need to do it very rapidly. I'm normally a little more conservative than Mukesh. I would only do it in progressive field loss in these patients. And sometimes we also do it in cases which are not of transverse sinus or thrombosis, which are not responding to medical treatment. So other indications for persistent disc edema as well. But very rewarding. As he said, even no PL cases, you sometimes get back great vision. Great presentation. Lovely video, Mukesh.
Thank you, sir.
Yeah.
Just to add one line, yes, dural sinus thrombosis patients, they fare a little bit poorly. Like they do not give you that kind of result as it is there in idiopathic IIH. But yes, it is a very rewarding surgery, no doubt about it.
Okay, thank you, Dr. Mukesh. It really was a very nice presentation. We now have two case presentations by young fellows from Shankardeva Netralaya, who I'm sure are blossoming under Dr. Kasturi's guidance. So I'm first inviting Dr. Yashdeep Das for his case. Dr. Yashdeep.
Thank you, ma'am. Is my
Yes, we can
presentation
see.
visible, ma'am?
Yes, it's visible.
Uh,
Go to slideshow. Slideshow.
is it visible, ma'am?
Yes, please go ahead.
Good evening, all the respected teachers. So today I'm presenting a case. I'm Dr. Yashdeep Das, and I'm thankful and grateful to all the teachers for giving me this opportunity to present this case, especially to my mentor, my guide, Dr. Kasturi ma'am, for giving me this opportunity. So, so basically, a patient presented to us. She was a 43-year-old female with progressive insidious bilateral diminution of vision over past 5 months. She reports of dull, diffuse headache, for which she has been taking on and off painkillers from the local pharmacy. She consulted a nearby local hospital around 10 days back, where she was diagnosed as a case of bilateral optic neuritis. She was ordered for an MRI and was ordered for starting IV steroids. She refused that, taking the treatment there, and came to us for a second opinion. When the patient came to us, we had the physical examination where the patient was a obese with BMI being 35.9, known case of essential hypertension and hypothyroidism. The husband says that he noticed loud snoring of the wife at night, for which they consulted a pulmonologist and the sleep study was done. And the findings were suggestive of a pathological breathing disorder. Coming to the ophthalmological examination of the same, so the best corrected visual acuity was counting finger at 2 meters in the right eye and hand movement in the left eye, and the patient was brought into the OPD by the husband holding her hands in a wheelchair. The IOP was within normal limit. The adnexa and the extraocular movements were within normal limits. The pupillary examination showed a mid-dilated pupil, which was sluggishly reacting with no RABD seen on swinging light flashlight. Then we come to the anterior segment examination, which was again within normal limit. And then we come to the retinal examination where we could see this fundus picture. In the right eye, we can see that there was a so basically, it was a case of bilateral papilledema that we could see. Uh, so here we can see that that in the right eye there is a edema obscuring around whole of the disc, just remaining a superior part of it is not obscured. We can also see the exudations and also the hemorrhages. Also, we can see the RN filled edema there. Tortuosity of the vessel is visible, although less, but the edema is also there in the left eye as well. Uh, so then we had the MRI of the patient with us as well. And once we saw the MRI and saw the radiological reporting, we saw that it was a T2 weighted MRI showing a empty sella, which can be seen in this transverse and incisor sagittal section. The patient was diagnosed with a case of IIH with severe vision loss and chronic papilledema. She was sent to the neurologist for an opinion, and they performed a lumbar tap, which showed out to be the opening pressure to be 32 mm of water. She was sent back to us for optic nerve fenestration, and since the worsen eye was the left one, so that's why we planned for the left eye surgery. So this was the ultrasound that we saw, that we took before the surgery. So as we can see there in both the ultrasounds, we can see that there is significant amount of fluid around the optic nerve, in the right eye being around 3 mm and in left eye around 2.7 mm. And this is the surgical video of the same. As sir already told, that there are many approaches to go ahead with approaching the optic nerve. So here, as we can see, we have marked the optic nerve distance and everything. And we have then gone ahead with the surgery with the approach that we tie and separate the SR and the MR, and then we reach the intraconal space. And as we find the optic nerve, we put a stab incision and we can see the gush of CSF coming out of it. And then we make a 1 into 1 mm of cutout from it, of the dura mater, and making a fenestration. So and then we do the closure uh, of the surgery. So this was the post-operative 1 week of the patient, where we can see there is significant reduction in the optic nerve, in the disc edema in the right eye, as well as it, although very subtle, but we can see in the left eye as well. In the right eye, we can see the obscuration of the vessels, the height of the edema, everything has been decreased, and the patient gained a vision up to 4 meters in the right eye and up to 1 meter in the left eye. And she was ambulatory the last time she visited us, and we had started the patient on acetazolamide. And this was the post-operative USG, which we can see after 1 week, where there is significant reduction of the fluid around the optic nerve. And finally, as we summarize the case, as the patient presented to us with CF 2 meter in the right eye and hand movement close to face in the left eye, after 1 week of optic nerve fenestration surgery, the patient became ambulatory and can move around with a best corrected visual acuity in right eye to be CF 4 meter and in left eye to be CF at 1 meter. Thank you so much, everyone, for your kind attention. Thank you, ma'am.
Thank you, Dr. Das. That was a really very well demonstrated case. And Dr. Mukesh, would you like to comment since it's just very close to what you've been doing?
Yeah. Yes, actually, this has been nicely highlighted. And if one get patient early, then we should not wait till this stage. Actually, problem is that we do not get patient sometime early. Neurologists, they do not send us patient on time, and then patient land up in this kind of situation where vision is significantly low. But very nicely managed case as a whole. And I think this patient will gain more vision in due course of time.
Yes.
So is there any role of steroids after you've done the fenestration? What do you do to help with recovery? Is there anything else
Yes,
that is done?
I do give short course of steroid in all patients, 2 week course of steroid, oral steroid in all cases. And that's part of my protocol, because whatever inflammation is there due to your own surgical procedure, so that needs to be taken care of. But not very heavy steroids. Typically for a like I give 1 milligram per kg body weight to start with, and then taper it.
Okay, I think we'll go on to the last speaker now. Thank you, Dr. Das. That was very nice.
Thank you,
Dr.
ma'am.
Farnaz, Dr. Farnaz, are you ready with your case?
Yes, ma'am. Hi, hello, and a very good evening. I'm Dr. Farnaz, currently fellow in ocular oncology and oculoplasty at Center for Sight, Hyderabad. So at the outset, I would like to thank the ARC, AIOS team, and Dr. Kasturi ma'am, Dr. Anita ma'am, and my mentor, Dr. Santosh Anawar, for this opportunity. So I'll be presenting one of the interesting cases which we have in our series of optic nerve gliomas. So we had a 7-year-old female child who presented with chief complaints of gross diminution of vision in the left eye, noticed for the past 7 days. This was also associated with left eye proptosis, gradually increasing over the last 3 months. There was no history of trauma. There was no history of swelling or pigmentation noticed anywhere else in the body. This was pertaining to neurofibromatosis, and there was no significant family history. The systemic examination was within normal limits. Neurological examination, there was no focal neurological deficit. The cranial nerves pertaining to the eye examination, the second nerve, right eye, everything was normal. So in the left eye, the visual acuity was perception of light present, projection of rays accurate. Whereas the pupils had grade 2 relative afferent pupillary defect. Extraocular movements were full, and also the fifth nerve, corneal sensations and facial sensations were intact. So coming to ocular examination, the head position was erect. The eyeball position, the left eye had 30 degrees of esotropia, however, taking up fixation on alternate cover test. The rest anterior segment was normal. Specifically, there were no leash nodules, and pupils, as I had already told, there was grade 2 RAPD in the left eye. So this clinical picture shows left eye 30-degree esotropia. However, the extraocular movements were full, and the left eye also had 3 millimeters of proptosis as measured by the Hertel's exophthalmometry. Moving on to fundus examination, right eye was completely normal, whereas the left eye had diffuse disc pallor with no optociliary shunts. So based on this clinical situation, compressive optic neuropathy secondary to an optic nerve tumor, because that's the most common cause of axial proptosis in childhood, it was suspected, and radiological investigation, MRI brain with orbits with contrast was advised. So this showed a well-defined lesion, which was iso-intense on T1 weighted images and hyper-intense on T2 weighted images, especially in fat saturation sequence. And post-contrast enhancement was also there, which was homogeneous in nature. Hence, a clinico-radiological diagnosis of optic nerve glioma with chiasmal extension was made in this 7-year-old child. In view of chiasmal extension, basal Humphrey visual fields of the right eye was done, and this was found to be normal. So in this clinical situation, the logical treatment options would be stereotactic radiation therapy targeting the tumor, chemotherapy followed by stereotactic radiation therapy considering the age, incisional biopsy to confirm the diagnosis followed by chemotherapy or radiation based on the histopathology. Since the child was 7-year-old, we preferred the first management option, stereotactic radiation therapy directly. To briefly get into the discussion part, let's have a look at how stereotactic radiation therapy in any modality is given to optic nerve tumors. So first, T1 weighted axial and coronal images with gadolinium in contrast are registered with a planning CT before the procedure. The gross tumor volume is defined as the area of contrast enhancement on both axial and coronal MRI images. And this gross tumor volume, when it is expanded by 1 to 2 centimeters in all the directions, we get the planning target volume. So target specific gradient of radiation therapy, the area of tumor, which is the area of interest as marked in the first image on your screens, this receives the maximum, that is 95% of the prescribed dose of radiation, followed by the second image showing the surrounding area that receives 50%, and thereby the third image which receives only 20% of the prescribed dose of radiation, thereby preventing collateral damage. So EBRT in optic nerve tumors is given under steroid cover, and that is why we call this as neuroprotective EBRT. So with oral prednisolone, 1 milligram per kg body weight, followed by tapering every 1 week, and also 10 milligram after the taper is continued for 2 weeks post EBRT. So this is accompanied along with B complex and also antacids, thereby making this neuroprotective EBRT. Let's have a look at how our patient had dramatic improvement post EBRT 6 months. So these clinical pictures and also the MRI show resolution of strabismus, dramatic improvement in vision from PL plus to 6/9 with reduction in the glioma size and complete resolution of the chiasmal component as well as depicted here in the FAT-SAT sequences. Now, even Humphrey visual fields was possible in the left eye, though the visual fields are bizarre because the quality of vision is not complete despite the great amount of improvement in the visual acuity. Optic nerve gliomas are relatively rare lesions that comprise 1% of all the intracranial tumors. Still, 3 to 5% of all the pediatric brain tumors, but the most common optic nerve tumor, especially in childhood. So we had analyzed 15 optic nerve gliomas in our observational study where we looked for demographics, clinical features, treatment strategies in both optic nerve glioma and optic nerve sheath meningiomas. So diminution of vision and proptosis were the main clinical features. MRI brain with orbits with contrast enhancement, which is the preferred modality of imaging, was done in 100%. EBRT was the most widely used treatment, almost in 67% of patients, and still 72% had stable or good visual outcome. To conclude, the optic nerve gliomas can be diagnosed clinico-radiologically, thereby restricting surgical intervention only to cases of disfiguring proptosis or intracranial extension. Early diagnosis with fundus examination, requesting the correct MRI with precision of reporting, easier access to us, that is neuro-ophthalmologists or ocular oncologists, early diagnosis and accurate treatment with neuroprotective EBRT, even in cases of chiasmal extension like ours, can lead to better visual outcome or stability. Thanks a lot.
Thank you, Dr. Farnaz. That was a very good case, and you have very nicely demonstrated how to diagnose and how to manage these cases with a very good outcome. Excellent case. Dr. Kasturi, this was a really wonderful program. My only regret is that there weren't enough people to listen to this. I hope it's made into a video and it's on YouTube, because it was really an excellent, all the speakers, all the presenters, really wonderful. I mean, so much of knowledge to gain. It's really a very nice program, and I think we should have more programs of this, and maybe with a little wider audience, so that everybody is, recognized for all the good work that they're doing.
Yes, Anita, it is a very targeted, topic, and really amazing. All the speakers are very good. But this is going on YouTube, and there are lots of people watching it, both in Facebook and YouTube. And I'm happy that, but we couldn't take the questions directly because I don't know why the chat box question has not come to us. But all the speakers, and especially the chairperson, Dr. Grover, everyone has given us such good insights. And I feel that it has really enhanced our clinical understanding, surgical insights. And the best is whatever little discussion we could do, it was very thought-provoking. So with this, I think I'll ask Dr. Grover, sir, to give the concluding remarks, because we have overshoot our time. And sir, please, your remarks. And
So I second everything what Anita said. An amazing webinar where we have learned a whole lot of things, and people who spoke about each of the individual things are really the topmost persons in that field, and it was really educational to hear that. And from the first talk to the last, they were all brilliant, especially the starting with the anatomy one. Everybody else is a star, so we expected it to be great, but the anatomy one and the two case presentations were also brilliant.
Nice.
So thanks to our juniors, and they are really taking the oculoplastics forward. And thank you, Kasturi, for designing this program. It was really well designed and really wonderful speakers. And of course, ARC AIS for their great work. And Anita, as always, fabulous. Thank you.
Thank you, everybody. Thank you all.
Wonderful moderating the whole session. And also, I'd like to thank every one of you for joining us for this webinar today. And I hope that this session has really added some valuable learnings to all of us. And look forward to welcoming all of you in the future events and for all your support and cooperation. So with this, I think we'll conclude. And thank you, Dr. Mukesh, Dr. Farnaz, Yashdeep, Sir, Hanita, and Ruju, and Tarjini, and also the support team. So this we conclude.
Thank you.
Thank you very much.
Thank you.
Thank
Bye.
you. Thanks a lot.
Bye.
Bye.